Welcome to the SuperPod podcast. I'm Emily Ball from Active Step Foot and Ankle Clinic, and I'm delighted to be joined by Dan Fallon, one of the founders of Renegades Gym in Portsmouth, and also the author of Start With One Thing.
Hi everybody.
How are you doing?
Yeah, good Emily, thank you very much. Thanks for having me on the show.
No, it's gonna be good. I think this is gonna be a good one, Danny. Tell me a bit about your background.
Well, obviously where we first met, so I was a PT in the Royal Navy. I joined the Royal Navy 2002, then I transferred over to the PT branch around 2007, 2008, and then became a rehab specialist in 2012, I think it was. And then that's where I started working the Regional Rehabilitation Centre in Portsmouth, and that's where we met. Yeah. And then since then, my thirst for knowledge has just grown and grown, looking at different aspects of how we can make people become more aware of their movement patterns, how they can teach themselves to move better so they're not always got these biomechanical, as people label it, problems which give them pain. And yeah, since in the last 6 years I've done contract work for the MOD. I still work for the MOD. And then just of recent, we developed the Renegades Gym during the lockdown, during a pandemic, yeah. But to be fair, we opened the doors and we was full. And since then, we've moved even closer towards the performance element by opening another studio, which is going to focus purely on performance and rehabilitation.
Which is your passion? Which
is my passion, yeah. I mean, working with people to get them to perform at their maximum level. So, yeah.
Now, I know functional rehabilitation is your primary focus.
Yeah.
Can you tell people that are watching this what that means? It's a bit of a sort of buzz term.
It is buzz term, functional conditioning, all those sort of buzzwords, but I'll give you an example. So recently, when we had the lockdown restrictions lifted in the July and gyms opened, I had a patient that had just had knee surgery, and the only stuff he was doing was stuff, well, and very limited obviously because of the circumstances, was some soft tissue work and all the sort of stuff that a physio would predominantly do. And when he came to me and I got him doing, you know, everything, what he was capable of doing, working within the range of motion, he was like, I didn't expect this. You know, he didn't expect to be going on an assault bike. He didn't expect to be doing squats. He didn't expect him to be doing, you know, some lifting, deadlifting, all these sort of movement patterns that are very, very important.
Why do you think he wasn't expecting that?
Because of the perception that people have on what rehabilitation is. They think that they're going to get a bit of band, they're going to do some little exercises, and they're going to do this real local stuff. But
being particularly focused on the area.
The area, and not realising that the area is probably just going to be the symptom. The problem probably came from elsewhere. And I mean, there's no right or wrong way of doing rehabilitation. I'm not saying that. What my approach is, and what it always has been, is functional first. See where we are, and then delve deeper when we highlight these problems. I mean, we've got him now almost back to running, and I'm looking, you know, assessing his running gait and looking at, right, we still need some range of motion in his flexion of his knee, because that's his limiting factor for his knee lift, for his heel lift, sorry, not his knee lift. And then we're looking at, you know, his Oxford scale of his quads, and do you know what I mean? So, but we didn't
these
start
are kind of performance measures. Yeah. Okay.
We didn't start there. We started with function first, because I certainly with people that are quite active and used to be fit. You know, he's an ex-boxer, so I often find if you go straight for the therapy and the sort of real local route, I often find that I lose people.
Yeah.
So if I go and do something that he's capable of doing to start with, which is quite exciting for him, and I get him on side, or her on side, I often find then we build that relationship, and it's like, all right, it's not going to bore me to death. And I'm not saying that rehabilitation is boring, because it is actually.
It's very repetitive.
It can be,
because it takes a lot of commitment.
And
I think that is actually a limiting factor quite often.
It's habit, isn't it? So, and I think if we habit stack, so like when we have to go deeper, so with his balance, I'm working on his balance as well at the moment. So rather than putting balance in his program, I'll say, when you're boiling the kettle, do the old balancing,
yeah.
And I think, what's his name, Dr. Chatterjee, is it? Rangan Chatterjee, got the other podcast, Feel Well Better. Anyways,
there's a couple that talk about habits. I know that you've got Atomic Habits as well, which talks about habit stacking.
Stacking the habits, and that seems to work better for him, because he's an ex-powerlifter as well, this guy. But he's probably one of the stories of recent where that approach has really, really worked well.
Sure.
So functional rehab is actually looking at the person and getting them doing something that's more conducive to their ADLs or their sport.
And what's an ADL?
So your activities of daily living. And
get that clear.
Sorry. So that we can get them performing very soon, and then the approach that I will always take then is where we start to find limitations is then delve deeper and that sort of stuff.
There's a lot of similarities with what we do actually, because a lot of people will come and see me with maybe, I don't know, let's just say a foot pain, okay?
Yeah.
But our assessment is actually looking at the whole body and looking at how maybe that pain has been influenced by their movement and function.
Yeah.
And I can guarantee you, if I literally just focused on the foot, they probably wouldn't reach their goals.
No.
So it's a similar ethos.
They would be back.
Yeah, absolutely. Because actually, the site of pain isn't necessarily where the problem started, or it might actually be a symptom of a wider problem elsewhere.
Yeah. And I also think with the functional side of things, you're giving the patient the empowerment.
Yeah.
Because I think certainly I've heard some pretty horror stories where people have been referred to certain physios in certainly in this area, and they've stuck some needles in them and they've done some manual therapy. It's
quite palliative, isn't it?
It's pacifying the problem. And there is a place for that.
Sure.
100%. And I do work closely with South Coast Treatment. They use our space as well. South Coast Treatment. Their physio. They work quite closely with us as well. And I'm always happy to refer back to them if I think that they need that sort of stuff going on. But I think when we go down the functional route, we're empowering the person to self-manage. And I think that's where the difference between somebody that has that approach gives them that empowerment. No matter what, are people quite fearful that they'll go elsewhere and they want them to have that crutch and reliability on them, and that's why they stick with the manual therapy and the needles and stuff. But at the end of the day, all my patients that I've had so far still come back to me because I've built a relationship with them, I've empowered them, but they still want to learn more.
But also I think, and I'm thinking about you, because I know a bit about your injury history as well.
Yeah, I've got an injury at the minute again.
The best clinicians are the ones that have maybe experienced some issues themselves. But I know from your experience, I know you would love to be running marathons, but actually you can't do it anymore. Can you tell us a bit about your story?
Well, I think that's what drove me. So the military give you the opportunity to do what they call the Exercise Rehabilitation Instructors course, which we used to be in Headley Court. And at the time, I'd had ankle surgery, I'd had knee surgery, I'd had a fractured neck, I'd had back problems, and
a great advert.
And I just had all these problems because where people say, "Oh, the mind will always give up first," I always challenge that these days because I'm like, my body gives up before my mind gives up, and maybe that's because I might have a piece missing up here. I don't know, me psychiatric help or whatever. But I'd had so many injuries, and I was in a lot of pain all the time, and I just couldn't get my head around how I was in pain. Even when I went on the RI course and I learned all about clinical anatomy, how the body works, and everything like that, I still didn't get within myself how I needed to manage myself, because dialing it back as a PT in the military is a really difficult thing. And it wasn't until I met a lady called Claire Booth of the Strong First community that she really taught me how to interact with myself, so that mind-muscle connection. And that's when things started to change for myself. That's when I started to look at things differently. With all the clinical knowledge that I had and with the strength-based knowledge that I had, I started to sort of put things together and sort of formulate a pattern that I would often use with my patients. So, yeah, but I mean, pain is a very subjective experience. And so people just crack on, and I'm doing that at the moment. I've got a bit of a hip problem, and I think I managed to do a lot when I did 9 marathons on a ski egg. Now, if you've never seen a ski egg in your life, Google it. And they were made for.
This was your challenge for the British Legion, wasn't it?
Yeah. So this was in the last lockdown in November. So basically, this machine was made by Concept 2 for the Nordic ski community. Now, Nordic skiers are known for having massive capacity, heart and lungs wise, and we invested in quite a few of those machines in the gym. And whilst it was open, I was putting I always call patients my clients through their work, and I was getting involved in it myself. Then I started to see whether I could do 5k. Then I started to see whether I could do 10k on it. Then I was looking at 20k, and I did a half marathon one day. And then when the lockdown happened, I was sort of like, and I was quite. It touched a nerve because the RBL couldn't go out there, so the Royal British Legion couldn't go out and do their normal poppy appeal. And I'm quite close with that community. And Claire, the local lady, so she rang me, and I said, look, listen, I don't know what I was doing, to be honest. I just said, I'm going to do 11 marathons. So she went, what do you mean? I went, on the ski egg. She said, what the hell is a ski egg? So I sent her some videos, and she had a look, and she was like, oh my goodness me, just with your arms. And it's sort of just with your arms, but it's not. You've got a bit of a hip hinge. So then I got to 8, and then I got home one night, and my mum said that she's got COVID symptoms, because my mum was with us at the time, because my wife was at sea. And I was like, what do you mean? She went, I've lost my taste and smell. I was like, oh my goodness me. So I went and got tested. I did the 9th marathon on that day, and I got a text saying, you positive COVID test. And then I didn't feel well in myself, but I just thought it was because I was doing loads of marathons. So then
one would.
Yeah. And then I think I inflamed my lungs. But then when I went back, I injured my hip. It's just been so tight. And I did have I think I had a labral tear anyways. It's been there for quite some time, but I've just sort of ignored it. And this is where people get to, I think, until something they really want to do gets in the way, or they can't do what they really want to do, they're in pain, they leave it right up until that point, till they see somebody like you and I.
Well, this is the thing, and I see it all the time. A patient will come and see me, and I'll say, okay, what's the problem? What's brought you to come and see me? I've got a problem with my knee, foot, whatever it is. Okay, so how long have you had that for? Oh, I've had it for years. I say, okay, tell me a bit about your pain. Oh, yeah, it gives me trouble every day. Okay, so why have you left it so long? And it's because it's become a limiting factor in them achieving something they want to do. Yeah. And that has been the trigger for them to actually go and get it sorted. And it's a really common thing. So people don't come and see you because they're in pain.
No.
They come and see you because that pain has actually become a factor in them not being able to do what they want to do, whether that's through playing with the grandkids, running 5k park runs, I don't know, going walking at the weekend. I don't know, it could be anything. Walking the dog. Yeah.
And I always find it's a priority as well. So it might be something that's higher on the priority list. So they might go, walking up the stairs is not the same. But I can still get up the stairs. I can get in the bath, okay. And then there'll be something that they really, really need to do, or they really like to do, and then that's when they come and see people like us. And I think not enough people really know which clinician to go to. I mean, I don't understand why people still go to the GP for musculoskeletal advice. General practitioner. Doctors don't tend to know a lot about musculoskeletal conditions.
Or the granular detail of
the granular
anatomy.
Details. No, they know generally. And I think certainly of recent where they've had that self-referral to physio. But even then, it depends on where you're at, whether you do need a physio, whether you need a podiatrist, or whether you actually just need some exercise rehabilitation experience to guide you. And I think not enough people know which practitioners to go to. Like
Sure.
a lot of back pain patients now are going to chiropractors, and again, not to bash the chiropractors, because I do know two specifically I know, and one actually is in this area. Two specifically I know that I really enjoy what they're about. But there was one guy who came to me. He had a fused ankle during the start of COVID. So then he was left to his own devices, and he ended up having back pain. Went to a chiropractor, paid £800. Chiropractor x-rayed him and then said, "I'm going to change your spine." And I was just like, when he was telling me the story, I said, "Are you sure?"
Sounds terrifying.
Are you sure? Are you sure that is exactly what he said? "Yeah, mush." I was like, okay. So then, like, as our rehab.
Did he change it?
Well, the more he sort of worked, so bear in mind, he was going to see the chiropractor, he paid £800 for this course. Every time he saw the chiropractor, he was only seeing him for 10 minutes maximum. When he was coming to see me, I was giving him the full hour, what he's paying for, you know, and we were doing all sorts. By the time, because he came into my place on crutches still, by the time we'd finished over, I think it was 12 weeks, it was about 12 weeks, he was, you know, he was almost walking. I mean, don't get me wrong, he's had a fused ankle, so he's going to have some limitation and some gait alteration, but I ended up taking the mickey out of him quite a lot, because we had a good rapport, and it was a bit of a, you know, quite a tough block. I'd taken the mickey out of him. You know, that chiropractor's worked wonders, hasn't he? Yeah. I said, I don't even think he went and got another scan to see if he'd changed fat. I think he just.
But I think, as much as you haven't necessarily nailed this issue, I think the issue is that we don't work together enough.
No. No.
And one thing that I really encourage my team to do is look at their cases and say, okay, who else would this person benefit from having input from? Yeah. Because I can't solve all the problems someone has. You know, it might be that my intervention will get them so far. Yeah. And then I've got to move them on. Yeah. And I think that's the problem is too much within healthcare generally. People hold on to their patients and they don't spread the love. Yeah. And
I don't think the education around pain is sufficient enough as well. I think the more we can explain pain, who's the guy who does that? Explain pain, is it?
Explain pain. I don't know, but it's got a ring to it. Maybe it's my book there for you.
It's got his name. It's not Louis Gifford, is it? It's is it Mike? Anyways, the more we can explain the pain to the patient, and this is another thing where you say to other clinicians, you go, you know, send them the video of, you know, maybe what's his name, Peter O'Sullivan over in Australia, without context though, and you go, "Oh yeah, I sent them that video. Did you explain what he's trying to say?" Because what that can do is segregate yourself from the patient as well. So what you're trying to say, it's all in my head. What this pain that is actually keeping me up at night is just in my head. No, that's not what we're saying. And if you just send them videos and stuff without the context around what you're trying to explain to them, that can put a lot of space between you and the client and the patient. So I think when we explain pain to the patient, we need to be also aware that we're not diminishing the fact that they're in that pain. It is real, and certainly when we start to talk about the biopsychosocial model as well, where we're talking about social factors and psychological factors that play a significant part of their perception of pain, you know, and
success with rehabilitation.
Definitely as well, and it needs to all encompass. I mean, just talking about my own experience with my back trouble that I had, my pain significantly increased when I left the Navy, and you know, I left the Navy. My wife was pregnant. I was starting a new business, which basically went on its ass, and then my dad had cancer, and then all of a sudden everything that is around me socially and psychologically, my pain was. I mean, I remember going into a school once to teach functional movements to kids, and I was literally sliding my left leg because it was so painful. But then, you know, as time's gone on, what's changed? Maybe my management physically and my approach to my own rehabilitation has changed quite somewhat, but more, I would say, my perception and my lifestyle and my psychology around pain, and understanding that it's okay to flex the spine, it's okay to lift up things because the spine is robust. And I think the more we see the physios in the NHS go down the medical route, I think there's going to be...
And just explain what the medical route is.
So the medical route is going to be just basically diagnosing what the problem is and not actually doing any sort of, again, functional rehabilitation or getting them to a stage where they can self-manage. So I think there's going to be a massive space where clinicians like us will have to take up the slack to explain exactly what's going on, because and that's no fault of the NHS physios themselves, that's just because of time. I mean, look at what we're under now at the moment. I mean, how many patients have gone amiss because of this?
Video or telephone consultations.
Which people as well don't engage with that. You know, not a lot of people engage with that. Even my own patients in the MOD, they just don't really tend to engage with it. And not just because it's the medium's not suited, but there's no real, you don't see body language, you don't see their face, you then can't see how they move. And
it's almost going back to that sheet of exercises, isn't it?
That's exactly what it is.
And it's, I know from my experience, the amount of people that I see that have maybe had an issue, maybe plantar fasciitis, really common in my field, had it for a couple of years, I've done everything, and then they bring out this page of exercises they were given a couple of years ago, and it's in my opinion, it's maybe not adequate or out of date, or it's not suitable for where they are in
it's not specific enough.
It's not specific enough. And then you look at their technique, which is normally completely wrong. And it's re-educating. It's like you haven't actually done what you needed to do, and you haven't. And if you were, you probably weren't doing it properly anyway.
And I think the level of detail where we get to. So, like someone said, "Oh, what's the difference between personal training and exercise rehab?" And I said, "Well, where do you start? I mean, the level of knowing one thing that Andy Milner always used to say to me, who was one of my biggest mentors, was if you know anatomy."
And Andy's
he's a physio, Royal military, not just Royal Navy, Band 7, should be probably Band 8 really, because he's
just quite a senior.
His brain is just extraordinary when it comes to the clinical world. And he's always pushed me to understand anatomy, because he said if you understand anatomy and you know and movement anatomy, then you more or less can then manipulate your own process or your own systems. And I think when you've got that level of understanding of what's happening and what, the external cues that we can give to a patient, all the external cues, the stuff that Gray Cook does. Gray Cook's another physiotherapist out there that's got a lot of good systems, the functional movement screens and all that sort of stuff. And he sort of says, put the person in an environment to then allow them to learn how to move. So, because sometimes you can tell a patient till you're blue in the face, but unless they know how it feels, and that's like, when they're doing a single leg squat, when you put a bit of band around their knees and pull them medially, and then their force is laterally, so then they're engaging their glute med more. Little things like that where you can really see a difference. And that's the level of coaching that I feel is quite different to personal training.
Sure.
Because at the end of the day, so most personal trainers generally have done a level 3 qualification, which allows them to write programs and stuff like that. But the coaching element of that, the detail that you can get into once you've started your journey in rehabilitation, because at the end of the day, you're learning how to fix people.
Yeah, and you've got to isolate the specific areas that you want to strengthen or like improve range of movement.
Or have an assessment process that allows you to sort of find why the symptom is the symptom and where the cause is possibly coming from.
Sure.
And that's the difference I often find.
Excellent. Cool, that's really insightful. Is there anything else any top tips that you would like to give any viewers today that have been suffering with an injury, that are in a lot of pain right now?
I think for me, and it's quite cliche certainly now in our field, but if you can understand the core and you can understand how the glutes and core interact with one another, so the glutes being this big muscle,
muscles.
and this whole area around here interacts with one another, and then the muscles that are coming through. If you can understand that or educate yourself on that and understand how you can the exercises that can help you take control of that area, more often than not, regardless what your injury is, you will see a difference, whether that be pain reduction or whether that be function increase. You'll probably see a big difference.
And you think that focusing on the core and the hip and glute area is probably integral to most injuries, whether that be the shoulder, the knees?
Massive. Well, you'll think to
limb.
yourself, where does most of the strength come from? The shoulder. So
Yeah.
I often say to people, if you can organise your spine in a way that your brain feels safe and it feels like it's locked up and it's stacked, as we say, then the force that you're going to produce from the limb will be far greater. Because if you've got an energy leak around here, all of a sudden your brain's going to go, oh, I'm not quite, and then all of a sudden you'll be hesitant. And I often find if you can build that relationship, brain to muscle to core, I often find that you get a better response. So, yeah.
Thank you. It's been insightful. Thanks very much for coming on today, Dan.
No problem at all. Really good to be on here.
Stay tuned for future episodes. We're going to have some more experts on that will be talking about other areas of the body and helping you back to your journey to health.